Here's something that might surprise you. A vitamin deficiency could be a missing link explaining why cardiovascular events spike in winter. We're not talking about scurvy or rickets. We're talking about vitamin D, and its role in cardiovascular health is far more profound than most people realize. Vitamin D levels plummet during winter months when sun exposure decreases. Your skin produces vitamin D when ultraviolet B rays hit it, but during winter, especially at northern latitudes, the sun's angle means UV rays don't penetrate the atmosphere effectively. You could stand outside for hours and produce virtually no vitamin D. This seasonal deficiency parallels almost perfectly with the seasonal increase in cardiovascular events. Now, correlation doesn't prove causation, but the biological mechanisms are compelling. Vitamin D receptors exist throughout your cardiovascular system. These aren't decorative features. They're functional receptors that influence critical processes. Vitamin D affects the renin-angiotensin-aldosterone system, which controls blood pressure. It modulates inflammation throughout the body. It influences calcium homeostasis in ways that affect arterial stiffness. It impacts endothelial function, the health of your blood vessel linings. Research shows that people with vitamin D deficiency, defined as blood levels below 20 nanograms per milliliter, face 30 to 50% increased risk of stroke and heart attack compared to those with sufficient levels. That's a substantial risk increase from a single nutritional deficiency. The challenge is that vitamin D's cardiovascular role is complex and not entirely understood. Supplementation studies have shown mixed results. Some demonstrate clear cardiovascular benefits. Others show no effect or even paradoxical harm at very high doses. This suggests the relationship isn't as simple as more is better. Part of the complexity involves cofactors. Vitamin D works in concert with vitamin K2 and magnesium. Taking high-dose vitamin D without adequate K2 might cause calcium to deposit in arteries rather than bones, potentially worsening cardiovascular health. Magnesium is required for vitamin D metabolism, so deficiency in magnesium limits vitamin D's effectiveness. Testing makes sense for most people, especially those at cardiovascular risk. A simple blood test measures 25-hydroxyvitamin D, the storage form. Optimal levels for cardiovascular health appear to be between 30 and 50 nanograms per milliliter. Below 20 is deficient. Above 50 might not provide additional benefits and could have risks. Supplementation should be thoughtful, not haphazard. Dosing depends on current blood levels, body weight, and individual absorption rates. Many people need between 1,000 and 4,000 international units daily during winter to maintain adequate levels. Some require higher doses, particularly those who are overweight, since vitamin D is fat-soluble and gets sequestered in adipose tissue. Food sources are limited but worth maximizing. Fatty fish like salmon and mackerel contain significant vitamin D. Egg yolks have modest amounts. Fortified dairy products and cereals provide some, though often not enough to achieve optimal levels through diet alone. Light therapy using UV lamps can stimulate vitamin D production, but this comes with skin cancer concerns. Most dermatologists discourage this approach for vitamin D maintenance, preferring supplementation as safer. The timing of supplementation might matter. Some research suggests taking vitamin D with your largest meal improves absorption. Fat content of the meal matters too, since vitamin D is fat-soluble. Taking it with a fat-containing meal enhances uptake. Geographic variations in winter vitamin D levels are dramatic. Someone in Miami might maintain adequate levels year-round through casual sun exposure. Someone in Minnesota or Maine almost certainly cannot. Latitude determines how seriously you need to address winter vitamin D. Age affects vitamin D metabolism too. Older adults produce less vitamin D from sun exposure even when UV is available. Their kidneys are less efficient at converting vitamin D to its active form. Supplementation becomes increasingly important with age. Certain medications interfere with vitamin D metabolism. Statins, some anti-epileptic drugs, and corticosteroids can reduce vitamin D levels or effectiveness. If you're on these medications, monitoring becomes even more important. Here's my practical recommendation. Get your vitamin D level checked at the beginning of winter. If you're deficient, supplement to achieve levels between 30 and 50 nanograms per milliliter. Include vitamin K2 and ensure adequate magnesium intake. Recheck levels midwinter to confirm you've achieved target range. This isn't just about preventing rickets or supporting bone health. It's potentially protecting your cardiovascular system during its highest risk season. The evidence isn't perfect, and we don't have definitive proof that vitamin D supplementation prevents winter cardiovascular events. But the mechanisms are plausible, the deficiency is common, supplementation is generally safe at appropriate doses, and the potential benefits are substantial. For many people, this represents a low-risk intervention with possible high reward.